So it's with great pleasure that I introduce Dr. Amir Toss. Dr. Toss is an assistant professor of pediatrics at the University of Arkansas Medical Sciences. He works as a pediatric endocrinologist there, providing direct patient care, and leads a clinical trial examining the effects of supervised exercise training in adolescents with insulin resistance and fatty liver disease. And today you're going to present on misdiagnosis of diabetes as common preventable risk factors for DKA. So thank you very much.
Well, thank you so much for the opportunity. And I'm sorry, I have a really long title, but it is quite descriptive and it could also be the summary slide of the presentation. So I would like to acknowledge and thank the other workers, other authors of this study, especially Dr. Annie Wang, who has been a great support and guiding person. We have nothing to disclose. I'll give two quick case presentations, but my intention is not to teach you how to diagnose diabetes or DKA in pediatric. You are all aware of that. This first patient is a 14-year-old male with no significant medical history, presented with altered mental status. He was in severe DKA at the time of presentation with a pH of 6.89 and A1C of 12%. He had neurological findings, therefore received 3% saline, followed by a CAT scan, which was normal. Altogether, it took about 60 hours for him to recover from DKA and transition to sub-Q insulin. In the history, we learned that he was evaluated at the PCP office 2 weeks prior to this admission for abdominal pain and nausea, and diagnosed with stomach flu, sent home on supportive care. I'm assuming this story is not unheard of for most of you. The second case could be a little bit more dramatic. A 16-year-old obese male with high-functioning autism. He presented in shock and completely unresponsive in mixed DKA plus HHS with a pH of 7.21, glucose undetectably high in our hospital laboratory, A1C of 11.5%. Unfortunately, he did not respond to aggressive fluid treatment and pressors, and he was announced dead 4 hours after admission. Hyperosmolar state thought to contribute to his outcome. His glucose at the time of death was 1150. Again, in the history, we learned that he was seen at an urgent care 2 days prior to admission and diagnosed with strep throat. He received an IM dose of Decadron and penicillin and sent home. So pediatric diabetes cases are on the rise for both type 1 and type 2. Here in this figure, we are looking at the numbers of new diabetes patients that are being cared at the Arkansas Children's. From 2005 until 2017, the numbers were somewhat stable, perhaps, but in the last 4 to 5 years, we are seeing a significant uptrend in the number of new patients coming to our care at the Children's. DKA is a common presentation for new onset insulin-dependent diabetes for both type 1 and type 2, and delayed diagnosis is the major risk factor, and there are certain factors that affect the delayed diagnosis, such as parental factors, medical provider factors, or system-related issues. But early recognition of diabetes symptoms is important to avoid DKA admissions. It's not a new concept. It has been known for a while, the misdiagnosis or delayed diagnosis. But I think it is fair to say that it is an overlooked phenomenon. It is understudied and perhaps not so much cared for. In this paper published in 2019, Dr. Munoz and the other researchers reported the numbers or the percentage of patients misdiagnosed by age group. So the participants were sent a survey, and these are the participants of the type 1 diabetes exchange registry. So either adults with type 1 diabetes or the parents of the children with type 1 diabetes received this survey, and they were asked about their pre-diagnosis experience. Roughly 18 to 20% of pediatric age patients were misdiagnosed according to the survey result. And when they gave the misdiagnosed conditions, it looks like more than half of the patients were diagnosed with some sort of a viral infection or flu instead of diabetes. And as a result, their diagnosis for diabetes was delayed. Another study from 2009 from Poland found that those with delayed diagnosis were more likely to have some sort of DKA. Here we see on the top part of this bar, compared to those who were diagnosed on time. And when they further analyzed the type of healthcare settings that the patients were seen at, they reported that 4 out of 5 patients were seen in a family doctor's office before being diagnosed or coming to the attention or admitted to the hospital. And they reported that the late diagnosis was responsible for 25% of all DKA admissions in their cohort. So the objective of our study was to determine the frequency of DKA as the initial presentation of new onset diabetes, especially among those with delayed presentation, which we combined basically combined missed and misdiagnosis together as delayed, and then analyze the missed or misdiagnosed cases at various healthcare settings before the hospitalization. That includes the characterization of the demographics and level of illness at presentation, and examine the misdiagnosed conditions. And our eventual goal is to identify and treat barriers surrounding the initial diagnosis and management of pediatric insulin-dependent diabetes at different healthcare settings. This is a retrospective charts review for patients admitted to our hospital between January and June of 2021 for new onset insulin-dependent diabetes. And Dr. Wang and myself independently reviewed the hospital records to assess the appropriateness of pre-admission management for the cases. And this is how we define inappropriate management for the sake of this study: inability to recognize new onset diabetes, including wrong interpretation of main diabetes symptoms, or inaction resulting in delayed management when the correct diagnosis was made. And I'm going to show the data later on that there are a couple of patients who were correctly diagnosed with diabetes, but they were not acted on correctly, unfortunately. So we had 152 patients new to ACH, Arkansas Children's, in the first 6 months of 2021. And we included 28 of them for analysis purposes, because the remaining 24 did not have type 1 or type 2 diabetes, or they were known to have diabetes, but they were new to our practice. Of the 128, 68 of them were seen or evaluated by a healthcare provider in the last 4 weeks. The remaining 60 directly presented to the emergency. And of the 68, we found 18 of them to be inappropriately cared based on our definition that I showed in the previous slide. And here we are looking at the a quick comparison of the all patients versus inappropriately cared patients. This may look like a little busy slide, but my point here is that 14% of all patients basically were inappropriately managed of this small cohort. And 8 out of 18 patients who were inappropriately managed came in DKA. And this number represents 13% of all DKA admissions in the first 6 months. And maybe more interestingly, 16% of all hypertonic saline and 37% of head CT recipients were among those inappropriately cared group. When we look into the misdiagnosed conditions, majority of our patients in this small cohort were labeled or diagnosed with some sort of respiratory issues, such as sinusitis or URI or even ear infection. And few of them, interestingly, received prednisone or decadron. 3 of them were diagnosed with a GI condition, such as stomach bugs or constipation. 2 patients were diagnosed with candidiasis, but they were treated symptomatically. There were no mention of any type of diagnoses in 3 of them. 2 patients were diagnosed correctly with diagnosis, but they were referred to outpatient diabetes clinic. 1 of them ended up in DKA and admitted to the ICU. Looking at the type of providers seeing these patients, majority of them were evaluated by the primary care physician, but there were few seen at local urgent care clinics or emergency departments. The median delay between presentation to the healthcare setting and hospital admission was about 14 days. And expectedly, the duration was a little shorter for type 1 diabetes versus type 2 diabetes patients. In conclusion, late diagnosis of pediatric diabetes, insulin-dependent diabetes, due to inappropriate care delivered by primary care clinics, urgent care clinics, or local emergency departments has led to clinically significant number of DKA admissions to our hospital in the first half of 2021. And Arkansas Children's Hospital is a medium-sized pediatric care facility, and we are only one of the hundreds of pediatric centers taking care of children. And we had that many patients who could have been perhaps prevented to be admitted in DKA. there are medical consequences for delayed diagnosis, psychosocial consequences, and economic consequences. So we should do everything possible to be able to minimize or completely eradicate such consequences. So as pediatric endocrinologists, we have a task to help primary care providers, help them to identify their knowledge gaps and fill them in, basically, by providing periodic and targeted education for the initial diagnosis and management of this condition to be able to prevent future preventable errors. There are a lot of different intervention opportunities, starting from the graduate school curriculums or graduate medical educations for residents and continuing medical education for currently practicing physicians or nurse practitioners or physician assistants. And finally, having community awareness campaigns to increase awareness of diabetes may also help to prevent future DKA admissions in our patient population. That said, I'd like to thank the organizing committee for giving me the opportunity to present today. I'll be happy to take questions.
Very much. I'll open up to either the floor. If you could, I'll repeat your question, or virtually. I guess I'll ask a quick question to you. So what are you doing now, based on this information? The first, when you were mentioning that at the end, I guess my first thought was this would be a good QI type project. So finding ways to improve the education and outreach to primary care doctors. Because I mean, honestly, I think all of us in Peds Endo see this as a problem. I mean, I just got finished with a week of hospital call, and I saw, very much the same thing in a very young child. It was third trip, and severe DKA was the final straw where the child was diagnosed.
Right. So the primary care providers are very heterogeneous nowadays. It's not just simply pediatricians anymore. So it's a group of people or providers, professionals from different backgrounds. So it's not that easy, unfortunately, to target one group and get a great result. Well, this is an ongoing study. I presented the data only for the 6 months, and we are about to complete the data collection for the last 6 months of 2021. And our next step is to primarily, and this data is collected from our hospital records. But first, I think we have to match whether this was really the case at the primary care settings. I mean, we rely on the history that we take from the patients, but is this true? Is this perhaps some patients were really advised to go to the hospital, but they decided not to? So I don't want to blame the primary care physicians at this stage yet, but compare and contrast their recording as well, and make sure that this data is true first off. And then I think second, I listed a medical and a nursing school intervention as an opportunity too. I think addressing the knowledge gaps of the current providers is one thing, but probably more permanent solution would be to make sure that diabetes is well covered in the curriculums of the medical schools, nursing schools, as well as during the residency trainings. Endocrinology is no longer a core elective, unfortunately. We have only a limited number of pediatric residents choose to rotate with us. Maybe that is another thing that we can also look into after confirming this data and discussing with the residency directors and such. But I don't have any one single answer to that, unfortunately.
Okay, well, thank you so much. I think, in the interest of time, we'll go ahead and move on to our next talk, and we're sorry for the delay, but thank you again for joining us. And again, thank you very much for submitting, and we hope to see submissions from you and see you in person next year.
Appreciate it. Thank you, sir.